Hi, Dr. Edie Zusman here. Welcome to the NorthBay Center for Neuroscience conversation about the spine. I'd like to introduce the other speakers who will be talking with us today about how to take care of low back pain. That includes the co-director of the NorthBay Center Spine Center, Dr. Christopher Rumery, and our superb spine-trained physical therapist, Sal Griffith. As you can probably see from the photograph, I'm a frontline provider, and at NorthBay, I'm taking all the precautions that are necessary to keep myself and our care team healthy. And I hope all of you out there are thinking of that as well. Today, our plan is to do 3 presentations in 1 hour. It'll be a comprehensive conversation, and I would ask you all, are you ready to stand corrected? So firstly, welcome. As many of you know, if you've been affiliated with NorthBay, we are the Mayo Clinic affiliate here in Northern California. And the model that we have at NorthBay is interdisciplinary and multidisciplinary. What that means is essentially whatever problem you have with your neck or back, we have the expertise, whether it's operative, non-operative, whether it's related to pain management, or minimally invasive surgery, then all of those can be evaluated here at our center. We use evidence-based best practices, and again, it's a comprehensive program, including operative and non-operative. And to introduce my surgical team, we work with Dr. Patrick Maloney from the military base, a brilliantly trained minimally invasive spine surgeon, Dr. Atul Patel, Dr. Sherry Taylor and myself, and our PAs, Corey and Vita. And the rest of our team includes, as we were saying, interdisciplinary and multidisciplinary. So our pain management team, we have our osteopathic manipulative medicine team. At NorthBay, many of you may already know, we have a 50,000 square foot wellness center with personalized training and guidance, including 4 swimming pools. We coordinate with our neurologists to help with the diagnostics. One of the very important programs at NorthBay is looking at how do we keep our patients healthy? How do we prevent surgery? And if someone needs surgery, how do we make sure that they're in good physical shape so that that journey is easy, and hopefully that they stay in good shape and protect their spines so that they don't end up with recurrences. And to that, we've included our nutritionist. We've got expertise in osteoporosis and prevention of compression fractures. We have world-class talent for neuroimaging. And then one of the things I'm going to talk about today is the diagnostics that we do. And that brings in our orthopedic team, including evaluation of the hip, evaluation of the sacroiliac joint, in addition to evaluation of the spine. You may have already seen the beautiful building that went up last year, our $20 million expansion with state-of-the-art technology. We use a minimally invasive approach whenever possible, which includes computer guidance, so that we actually plan the surgery in 3 dimensions and just execute in the operating room. And here's a picture of a class for our swimming pool. Some of our patients who have back pain, and maybe even some of you listening now, they're folks who, when you're sore, you get deconditioned. It's hard to get up. It's hard to be active. And what we found is a lot of folks do very, very well in the pool. If they can walk in the swimming pool, they can do their aerobic exercise, get their heart rate up. They find that the heat in the pool, if there's an arthritic condition, it helps them loosen up. And what we love about it is it takes folks who maybe were deconditioned and sore, and it gives them those first steps toward health. Our process is integrated, which means that all of the doctors work together. If there's an individual who's traveling to NorthBay from a distance away for their care, just like the Mayo Clinic model, we're able to coordinate appointments so that folks can see more than one of the providers on the same day. And so with that introduction to the philosophy behind NorthBay, I wanted to talk a little bit about causes, particularly of lower back pain. And as we said, sometimes people say they've got lower back pain, but there's a mixture of things in that lower back. Sometimes it's the middle of the back, called the lumbar spine. Sometimes it's the sacroiliac joint, which is part of the pelvis that's just off to the side. And sometimes it's actually hip pain that's causing the whole process to take place. So I'm hoping that by the end of my brief portion of the talk tonight, that each of you who is listening can actually figure out which of those or a combination of those is causing the symptoms that you have. That would be all inclusive of lower back pain. And when we look at the spine itself, the spine consists of 5 parts. The neck is obviously the area between the head and the shoulders. The thoracic spine is defined specifically. That's the area where every thoracic vertebrae or spine bone has a rib attached to it. The lumbar is below. And then we have the sacrum, which is attached to the sacroiliac joint. That's when it's below your belt. Dr. Rumery is going to be speaking with you all later, and he's helped me a lot with looking at this anatomy. Anything that's below the belt line, you want to think of as potentially either being lower back or possibly sacroiliac. And then we think of the coccyx as what would have been a tailbone. And when we as physicians, and for my team, the neurosurgical team and spine team, when we see a patient, we're trying to divide up the symptoms to think, what is the source of this discomfort? So a patient comes to us and they say they have low back pain, and it can be from a whole lot of different reasons, and that means it may have a whole lot of different solutions. And so what we're listening for are the clues of what's the pain generator? Where is that symptom coming from? So we can make the very best treatment recommendation. And in general, we think of the pain as coming from 3 different sources. If it's right in the middle, it's often from the bone itself. And we'll test that. Your doc here at NorthBay, or you can do that in your own living room. If you're standing straight and you're standing for a long period of time, and all of a sudden, after about 5 or 10 minutes, you start feeling like your spine is aching and it's right in the middle, a lot of times that's related to the alignment of the bones. Another possibility is if you lean backwards. If you arch backwards, that puts extra pressure on the joints of the spine called the facet joints. And that helps us understand that not only is it coming from the bones, but it may actually be from the joints. There may be an arthritic process in those joints. The joints in the spine are called the facets. So if it's a pain in the middle, if it happens when you're weight bearing and standing, sometimes it's alleviated when folks kind of lean forward on the shopping cart, or if they're doing their dishes, folks will tell us they put their elbows up on the counter. Think of it as something from the bones or axial pain. Then the next thing we listen for is a muscular pain. And a lot of times this comes on more suddenly. There might have been an event. A patient might tell us that they were lifting or twisting or playing basketball or sports when the discomfort came on. It may be asymmetric. It may be one side more than the other. And there may be a spot where they point right to it and they say, okay, this is the spot. And we can feel that it's from the paraspinous muscles, the muscles off to the side of the spine. And then particularly of interest and expertise for my neurosurgical team is when something's going on in the spine and it's causing a pinched nerve. And patients, some people will call that sciatica. It's a radiating pain that actually may involve a pain that goes to the buttock or down the leg. And when we hear that the pain is not just in the spine or not just horizontally below the belt, but it's coming down into the buttock or down into the leg, that's when we think about potentially there being a pinched nerve. And so breaking it down, when the pain is in the middle of the spine, a lot of times we'll have patients lean forward and backward to help us understand whether it's an issue with alignment or an issue with arthritis. Occasionally, it can actually be something even more significant, such as a compression fracture in some of our folks with osteoporosis, or if there was a recent fall. If it's a pain that wakes a patient up at night, especially if it's associated with weight loss or night sweats, we think of things like infection, and we think of things like cancer. With regard to the muscle pain, we talked a little bit about the fact that that's a little bit easier to diagnose based on the history, and folks will actually point to the spot that's tender. The nerve pain is an electric-like shooting pain. A lot of times that hurts more when folks are sitting or when they're stretching their leg in the sitting position. That's because the nerve's actually on stretch over the area where the nerve pain is originating. A lot of the folks with nerve pain and sciatica have something called a herniated disc. And the disc is the cushion between the bones. Sometimes there'll be a twisting motion that causes it to happen. Sometimes it happens without a clear event. But if that cushion ruptures, and I should say there are a bunch of different words you'll hear for that. Sometimes it's ruptured, herniated, prolapse, protruding. Some people will say there's a fragment of disc. But in any case, what it means is that the little cushion has broken off and it's pushing into the nerve. And that's the cause of leg pain and occasionally weakness, numbness, burning, and tingling. I did want to pause here for a second because there are two other causes of lower back pain that I want folks to think about when you're trying to figure out what you think is the cause of the pain. And sometimes it's the hip. And the hip is a little bit easier to differentiate. You can actually push on the joint at the side of your hip. And if that's sore, there might be a little bit of arthritis in the hip. And then what I would ask the folks to do is go ahead and rotate your knee in and out. And you'll see a little bit more of this with our physical therapist who's going to be showing how to do these different maneuvers. Additionally, there's a process in the sacroiliac joint that's important for us to think about too. And that happens off to the side of the spine. Folks will tell us that it really hurts when they try to cross their legs, and it really hurts when they turn to their side when they're sleeping. So those are the three different things. It's from the spine, it's from the sacroiliac, or it's from the hip. And so when you come in to see us, we'll do a detailed examination to try to help make sense out of all of those symptoms. We'll do some fancy imaging a lot of times. If there's a fracture, we might do a CT or CAT scan. If it looks like the pain's radiating and we're looking for where a nerve is pinched, that's when we use MRI technology. And in general, we don't really need to do spine x-rays anymore because regardless of what they show, we'd either do a CT or an MRI to make more sense of those. Every now and again, though, especially for somebody who tells us when they're standing for a while, it really starts hurting, we'll do something called flexion and extension x-rays, where we'll have the individual lean forward and take a picture and then lean backwards. And a lot of times for folks who have this syndrome called an anterolisthesis, some people will call it a spondylolisthesis, or the term I like to use is a slip, where one bone is slipping forward on top of the other. We'll actually see that on those flexion and extension studies. And all of this is so that if there is a surgical option, that we know that X marks the spot. We know this is where the symptom's coming from, and this is what we can do to treat it. And so at NorthBay, again, with all of the different tools and options that we have, it's really wonderful to be able to coordinate the care and make sure that every patient doesn't just get the best care, but they get the best care that's right for them. In the old days, fusions were kind of quite an event, and spinal fusions were done for a variety of reasons. For those of you who've been evaluated in the past for back problems or feel like you had a surgery and maybe are having different or new symptoms now, I think it's time to ask new questions. And the reason is that we have more technology. We have improved minimally invasive techniques. We have artificial discs that can be used for motion preservation. And I would just say that the idea that somebody's got chronic back pain and it's kind of a done deal. There was even a term used years ago called failed back syndrome. And that's not where we are today. So if you're somebody who's been listening to your body and really, really struggling with what's been going on in your back, I think our team would really love to take a look and see what's going on. And some of the technology that's so extraordinary for the fracture that you're seeing here, you can see that the alignment is off instead of the bones being straight, that there was a fracture. And so now we're able to do these little pins and rods to help with that. For folks with neck pain, we're able to make diagnoses of rare neurosurgical diseases that show the changes in the spinal cord or nerve compression. And I feel like where we are right now is thinking about the future of spine care, multidisciplinary. We're partnering with our patients, where patients are responsible for their health. They're doing beautiful core and strengthening. We're thinking of the continuum of care. How do we help a patient, not just with surgery, but with health? And then the technology is incredible. I wish I could give you all a tour of my gorgeous operating room. And so to me, I think the answer is, first, make a great diagnosis. If you've got low back pain, let's find out where it's coming from. Second, let's look at what is it going to take to help you get healthy. And third is, if it requires some high technology or the level of expertise that we have at NorthBay, I hope that you'll reach out and come and say hi. And with that, I'm going to turn the next part of our conversation over to a very dear colleague. I think at this time you're seeing a picture of my dog and our favorite vacation in the Alps. Dr. Christopher Rumery is a brilliant and talented colleague who I've known for a number of years. Together, we co-direct the Spine Center at NorthBay.
Good evening. Thank you for listening, and thank you, Dr. Zusman. When we get a patient that comes to us in pain management, I'm one of 4 pain management physicians. Our first job is to figure out why the patient hurts. Frequently, patients come to us with neck pain or back pain, which is a symptom, and we need to figure out what is causing the pain. One of the best things that's happened since Dr. Zusman came to NorthBay is that she has assembled a multidisciplinary spine team. We meet together once a month. We present difficult patients. We typically have 2 to 3 pain management physicians. We have 2 to 3 spine surgeons. We have physical therapists. We have osteopathic physicians. We have a neuroradiologist. The images are presented, the patients are discussed, and a collaborative plan is put in place. When patients come to us, there's 3 broad categories for treatment options. And one option is conservative, which I include everything that's not sharp. So that would be medications, physical therapy, water therapy, osteopathic manipulation, and acupuncture. The second option would be interventional pain procedures, which can include epidural steroid injections, nerve blocks, and spinal cord stimulation. And the third option for every patient would be surgical intervention. So I'm going to talk first about the cervical spine problem. So typically, patients present with either one of 2 symptoms. They come in complaining of neck pain, or they come in complaining of neck pain with pain that runs down their arm, sometimes as far down as their fingers. And when we look at the cervical spine, this is a side view of the cervical spine. So these are the bones that support your neck. There's a shock absorber between each one, which is the disc that Dr. Zusman talked about. The nerves come out of these openings and then go down your arm. And then there's a little joint called the facet joint that's in the back all the way down. This just shows the cervical spine, but that goes from your neck all the way down to your lowest lumbar level. If someone presents just with neck pain, the 2 most likely options or causes are muscular. The muscles aren't shown here, but you've got muscles on each side of your neck that hold your head up and let you move. And frequently, we'll send the patient to physical therapy or our osteopathic physicians who do osteopathic manipulation, or we'll give the patient a muscle relaxant to see if that helps them. If they don't get relief from that, and especially if they have pain with increased pain with looking up or looking to the side, that puts a load on these facet joints. And we will do a medial branch nerve block. These joints are innervated by the medial branch nerves, which aren't shown on this slide, but they're in this location at every level. And we'll put a small needle in and block those nerves. If you take away most of the patient's pain for 6 to 8 hours, that's considered a positive test, and that the pain is coming from those joints. The treatment for that is to go in with a different kind of needle and actually burn that nerve, and that typically relieves the patient's pain for a year. If the pain then comes back, you just go in and reburn it. It's about a 30-minute procedure done at the ambulatory surgery center. There's really no recovery time from that. The other common cervical problem that we see is someone that presents with neck pain, with pain that goes down their arm. And in that case, we're suspicious of a disc. You can go to that. You can go to that next one. Yeah. We're suspicious that a disc has pushed back into the nerve that's then going down the arm. And what we can do for that is to inject a steroid injection close to the nerve. And in about 2/3 of the cases, we can make that pain better or have it go away. And there's a close-up of that showing that. This is what we are looking at when we are in the procedure room. This is our needle. This is a front to back view. So we would be standing behind the patient or over the patient. Our needle goes in. This is a 45-degree view of that same needle position. You inject contrast dye to make sure you don't have an intravascular spread, because we want the medication to be around the nerve, not to go circulate throughout the entire body. And you typically see the contrast, which appears dark, layering out in the posterior epidural space. This slide, the previous slide was, our set of slides was an interlaminar cervical epidural steroid injection. This is a transforaminal injection. Occasionally, the surgeons want a very specific nerve targeted, and in that case, we would place the needle in this fashion that actually goes in from the front of the neck. That's what that looks like. And these are just the contrast images of that. Probably the most common thing that we see in pain management is low back pain. And once again, it is, there's 3 broad categories. It's muscular, which we have our colleagues in physical therapy or osteopathic manipulation handle. The 2 areas that we deal with mostly are back pain that runs down the leg, or just back pain that does not run down the leg. And Dr. Zusman addressed this in her talk. For us, even though the anatomy is different, the principle is exactly the same. Patients present pain that comes from their back that runs down their leg, sometimes into their toe, and they've got this disc is pushing on this nerve that then goes down the leg. We treat that with a lumbar epidural steroid injection. If the patient presents with back pain, worse with standing, better with sitting down or leaning forward, we do lumbar medial branch nerve blocks leading to lumbar radiofrequency ablation, similar to the procedures in the neck. Something that, can you raise this up a little bit? Or? This is half of the sacroiliac joint. And there's another bone that comes around on each side that forms the pelvis. That accounts for approximately 15% of patients presenting with low back pain. when we see someone whose pain is below the belt line in the, I call it hip pocket area if you were wearing jeans, we can do an injection of steroid into that joint. If we take away the patient's pain, the treatment for that is to go in and burn the nerves that go to that joint. There's a nerve that comes down from up here, and there's an opening here, here, and there. And we burn all three of those, and that typically lasts for several years. If that doesn't relieve the patient's pain, there is a sacroiliac joint fusion procedure that can be quite effective. Here are our x-rays of an interlaminar epidural steroid injection. You have to get at least 2 views to make sure that you're at the right depth and right location. And contrast dye is injected, and you see that flowing out in the epidural space. These are views of the lumbar medial branch nerves, and that's these white dots indicate where the nerve is. It does not look like that on x-ray. You can't see the nerves on x-ray. You place a needle. This is the lateral view showing where you would put it to block the nerve. This is the 45-degree view. We call it Scotty dog view because it looks like a Scotty dog. There's his ear. There's his ear, his nose, neck. And generally the nerve, our target is the eye of the Scotty dog. So we like Scotty dogs. This is a radio frequency needle that's being placed to burn the nerve. The only nerves that we can burn are nerves that do not have a motor component. Many nerves in the body have a sensory and motor component, like my finger. I can move my finger. I can feel my fingertip. You should not burn that nerve because then you lose motor function. So we don't burn any of the nerves that go down the leg. Frequently patients say, can you burn that nerve? And the answer would be, we could, but it would be a disaster. So we don't. We only burn nerves that go to a joint that don't have motor function. And this is a slide from Holy Week in Antigua, Guatemala. I was there several years ago. They make these carpets out of colored sawdust, and they make them, and then there's the procession marches over them, and they're destroyed, but they're incredibly beautiful until that happens. And that's the end of my talk. I'm going to introduce Sal Griffith. She's our head of physical therapy for our spine program, and she takes amazing care of our patients. Thank you, Sal.
Hi, thank you for joining us. I'm Sal Griffith, and I'm a physical therapist. Before I start with my presentation, I would just like to mention some self-tests that you can do at home. Dr. Zusman has mentioned during her talk that you can actually do a self-test at home to identify the source of your pain. So I'm just going to demonstrate. So she mentioned that when you lean backwards, the extension of your lumbar spine, and you start to feel pain on the side of your spine, not quite the center, but on the sides, that could be your facet joints. And she mentioned that when you lean forward and you start to feel pain on your low back, that could actually be a spondy or spondylolisthesis. And if you try to rotate your hips, as what she's mentioned, you try to rotate your hip in and out, and you feel pain on your hip, that could be your hip joints. And if you try a figure of 4 and you sit and cross your leg and you press down just gently on your knee, push it down, and you start to feel pain on this area of your back, that might be your SI joint. So I just want to mention that before I start with my presentation. And as a physical therapist, I see patients with different musculoskeletal conditions. Some will get better with physical therapy. Others will need surgery. And in this case, that's when we see patients to help them prepare for surgery. And some of them will have aquatic therapy. Some will have some exercises at home. But the goal is for them to be in the best shape as possible before they go on to surgery. So for this purpose of the talk, I will be focusing on how you can take control of your aching back at home. And as far as physical therapy is concerned, I think there are 3 ways on how you can simply take care of your back at home. So first is maintain correct posture. Second is to observe proper body mechanics. And of course, the third, exercise regularly. As far as posture, I think if you look up dictionary, posture is defined as how you position or you hold your body in space. For me, it's basically maintaining a correct alignment. As you see in the picture or on the slide, if you take a plumb line, a weighted plumb line, and you drop a weighted plumb line right beside you, as you see on the picture, that plumb line should go through your ear, your shoulder, your hip, your knee, and your ankle. And that is an ideal posture. When you're at your ideal posture, that's when you feel more stable, your muscles have less strain or stress, and you use actually less energy. But once you start to go out of that alignment, that's when you start to slouch. And you start to compensate by lifting your chin up and moving your head forward, as I'm doing right now. And it's I'm feeling strain on my back. That's when you feel more unstable. And if you're standing and you're doing this, you're actually feeling more unstable on your feet. And that's when your muscles have to work harder. And that's when you start to feel like you get tired quicker or easier. I just want to show you some pictures of good and bad postures, and I think it's quite self-explanatory. Again, going back to the plumb line test, as far as you can keep a good alignment of your head, of your ear, shoulder, hip, knee, and ankle, that's correct alignment. And once you start to move away from that correct alignment or the plumb line, then your posture is considered bad. And again, I've got more pictures to show you, self-explanatory. Sitting on a couch, if you see the first one on your left, the patient or the person is sitting upright, arms are supported with a pillow, it looks more comfortable, the spine is straight compared to the picture on the right, which is a slouch posture or bad posture. And again, if you're working on a computer, try to sit up straight, chest lifted up, chin slightly tucked a little bit, and think again of your ear, your shoulder, hip, and knee alignment. So same thing for proper body mechanics. If you are able to keep a good alignment of your spine while you're moving, you are able to observe proper body mechanics. Just like when you are working in your yard or doing some chores, and you're able to keep a good alignment, then that's proper body mechanics when you're moving. And I have more examples and pictures. So basically, if you've noticed, again, once you start to round your back, start to bend and round from your back, you're demonstrating, and while you're moving and doing things around the house, then you're demonstrating improper body mechanics. Just want to point out, again, the twisting. When at home, and I think most of us are kind of guilty with this because we always are in a hurry and we try to reach and twist at the same time. That's a lot of strain on your back, as you see on the first picture. And the second one just demonstrates that if you're working at a counter, it would be better if you're closer to the counter so you don't have to lean over forward. I think that's a little bit of an extreme for bending forward when you're brushing your teeth, but the same concept. Try to keep a good alignment of your spine, even when you're brushing your teeth. And I like the picture on the right side, actually. Again, I'm guilty with this, and I think it's just sometimes the way the tissue holder is placed, it's kind of way too far to the back. It's a lot of strain on your back trying to twist and reach over. If you have a way to put a tissue holder in front of you, a little bit closer in front, then you don't have to twist. Getting in and out of the bed, if possible. Same mechanics again. We're going to go back to the foundation of keeping a good alignment of your spine, is to try to go down on your elbows first, go down on your side, as you can see on the picture. I can't demonstrate as much, but I think the picture would show you that. Go down on your elbows, on your side, bring your legs up, stay on your side for a few seconds, and then roll on your back like a log. So that's what we call a log roll. And getting in and out of the car. So getting in and out of the car, if you already are suffering from back pain, it might help you if you go approach it backwards. So as you can see on the picture again, you move, approach it from backwards, and then you turn with your whole body and bring your feet in. With lifting, try to not round your back when you're lifting. If you can't avoid it, but you have to bend forward, try to hinge from your hips and not round your back. I've included a daily 10-minute exercise program, and I'm hoping that at the end of this talk, you would be able to have a 10-minute program that you can start once a day, and then hopefully later on, after maybe on the second week, do it twice a day, maybe on the third week, 3 times a day, just a 10-minute program. So the first one is postural endurance exercise. So basically trying to maintain a good posture when you're sitting and try to hold it. Make sure that your chin is tucked, your shoulder is back and down, chest is lifted up a little bit, and you have a little bit of a hollow in your low back, stomach is in, and then try to hold it for 5 seconds. Try not to hold your breath. So take a deep breath in, and you blow out through your mouth as you keep your stomach in and tight. And you can try that standing as well. Same process. You try to keep the chin tucked, shoulders down and back, chest lifted up a little bit. You have a good hollow, small hollow on your back. Stomach is in and tight, and try to hold it for 5 seconds. And try and see if you can repeat it 5 times or 10 times, whatever you can tolerate. And then for chin tucks, it's basically, as much as I can demonstrate, it's basically trying to move your chin down toward your chest. I'm going to go on my side view. So it's trying to make sure that your shoulders are down and back. You're trying to move your chin down and your head a little bit backwards, but not too much. Just be gentle with all these movements and make sure that you are not creating your symptoms or you're not reproducing your symptoms. And the next one is the scapular retraction pinch. So make sure that when you do this, your chin is already tucked and your shoulders are down, and squeeze the shoulders to the back and hold it for about 5 counts and see if you can repeat for 5 to 10 repetitions. Core stabilization exercises. So to activate your core, the deep core muscles, you basically try to draw your stomach in. You hold it in for about 5 seconds if you can, and try to establish a good breathing pattern. Take a deep breath in, Blow out through your mouth and hold your stomach in. Hold it for 5 seconds if you can. And you can make it more advanced by starting to move your legs. That's what you can see on the picture. You can start moving your arms, and then you can do alternating leg and arm to make it a little bit more challenging. But but what you would want to remember is to make sure that you're sitting up upright, sitting up straight, and your stomach is in, you're holding it tight, you're activating your core, and you're holding it tight throughout the time that you're doing the exercise. And don't forget to breathe. And I just want to mention that if you feel steady and stable enough at home, you can try it in standing. Make sure you're holding onto a countertop. Test your balance, hold with both hands. And if you feel steady enough, maybe one hand. And if you feel really steady, maybe just 2 fingers or no hand, but stay close to a counter for safety. And you can do some arches while you're standing up straight and activating your core by basically drawing your stomach in. So I hope you've learned something that you would be able to do at home. I hope it's easy enough. And if in case you're actually doing more advanced exercises, consult with your physical therapist or with your trainer. And that would be it for me.